All right, so you go ahead and move on to the next slide. So pituitary, thyroid, and adrenal disorders, right? So big thing. So we have our endocrine system. We're pretty well aware of this. You know, endocrine, they're mainly hormones, as mentioned. Those hormones, typically the book kind of placed it in a weird way, right? So the book says that hormones do specific things to specific cells, but also hormones affect the whole body and all tissues and everything. So it's kind of weird. Hopefully there's no question where it's like, what do hormones do? And then it says like, hormones will do very specific things with very specific cells, because they do. It's true.
Yeah.
Like our luteinizing hormone, or our FSH, our follicle stimulating hormone. Those are specifically to the gonads, right?
Well, you said it last week.
Mhm.
There are some
That
that
will-
affect all,
yeah.
and then there are some that are target tissue specific.
Exactly, yeah. Like for instance, insulin works for the whole body.
Yep.
And it does everything for the whole body. But our FSH, our LH, those are specifically to the gonads. So again, it's just to give you an idea that our hormones both can do things that are very specific, that will only affect specific organs via our chemical messages for specialized function, or they can do something very big like affect the whole body, like insulin does. Insulin is like the big
Thyroid
one.
hormone.
Mhm.
Right? Oxytocin is one that's like specific.
Our
right?
somatotropin, which is growth hormone, which will make you the whole body
Whole body.
work. Yeah. So long story short, typically it affects all tissues and cells, but don't put it past that there are some hormones that are very specific. So we can move on to the next slide. Yeah. But just keep that in mind, right? So we have about, we'll just cover that because we're in a public spot. So we have about 9 different adrenal glands. But the big ones that we're going to be paying attention to are going to be our hypothalamus, right? We also have a pineal, but we don't have to care about that. Our hypothalamus and our pituitary, our gonads, but we don't go too much into that too by the look of our slides and everything.
Mhm.
The thyroid, that one's huge. The parathyroid, that's behind the thyroid. The pancreas, which is obviously for
Yeah.
insulin and glucagon production. And then our adrenal glands, which are our corticosteroids or glucocorticoids, our mineralocorticoids. A big one, aldosterone. That one has a lot to do with blood pressure, maintenance, and all that stuff. And again, as mentioned, the pineal gland, but she didn't really touch on that. But luckily with the slides, I provided as best reference to what those different areas cover in terms of, like the pancreas will have our alpha cells, which make glucagon. Beta cells make insulin. These are our 3 different types of corticosteroids made by the adrenal glands. Different things like that. So our parafollicular cells from the thyroid gland makes calcitonin. Very important thing that helps us regulate calcium in the bloodstream. And then follicular cells from the thyroid makes T4, T3. This is thyroxine. And T3 is like triiodine. It's like a weird name, but it has 3 in it. And it's part of the thyroid family.
The T4 is tetraiodine something.
Yeah, that's like the chemical.
Yeah.
But long story short, that's like I provided as best reference to give like gonads, testosterone, estrogen, progesterone. So take a look at those when whenever you're able to. So we go on to the next slide. Right. So for negative feedback, that's the biggest thing. What do we know about negative feedback without really looking at the wall? Right. This one's talking about PTH and all that, but in general, what does negative feedback do?
It's like the hypothalamus, it detects when the levels of, like, for example,
Any hormone,
like
any bit.
corticosteroids,
Yeah.
Like-
Okay.
they're high,
Yeah.
then it secretes like
Hell, if anything, we can make it a little simpler than that, right? We'll use blood sugar, right? So the body feels that there's too much blood, too much sugar in the blood, right? High glucose.
Mhm.
So what is your body going to do in order to bring it? Because we have this middle ground right here. Like imagine there's a line right here. This is our steady state, our homeostasis. So now we have blood sugar That's part of homeostasis, but it's up here. We don't want to be up here, right? We want to be down here. We don't want to be down here either. We want to be right in the middle. So when we have it up here, in terms of glucose, what is our body doing to bring us back, or that negative feedback, to just bring us back to normal? What does our body secrete? Insulin. Which cells in our pancreas makes insulin? Beta cells, perfect. That's essentially what negative feedback is all about. It's trying to revert back to normal.
Shutting it off, right? There's
Pretty
enough of
much,
it,
yeah.
there's enough of it, we don't need more, let's shut it off.
Exactly. So, as mentioned, for the example, the parathyroid, right? It's right behind the thyroid hormone. The parathyroid's purpose, for the most part, is in order. It's like a single thing. It's not like the thyroid where it's as complicated. It's more just, hey, we have low levels of calcium in our body. Yeah, no, I'm sorry. To be more specific, in our blood serum, so blood circulation level, we're hypocalcemic, right? So because of that, do you guys recall what the parathyroid does to? We have low in our blood vessels, but we have some. Where do we have a lot of calcium in?
Extra cells. The bones.
Not necessarily.
Oh, the bones.
Yeah. So the parathyroid hormone will encourage osteoblasts or clasts.
Class.
Okay, to break down bone and pull calcium from the bones into blood serums. Right? Can you picture that in your head? What is that? What can that lead to? You know, if like you take way too much osteoporosis, because now you're having weakening of the bones. But the main point with negative feedback is that, you know, the PTH is noticing that there's, you know, or the hypothalamus mainly, is noticing that there's low levels of calcium. So it tells the pituitary to secrete the parathyroid stimulating hormone to release parathyroid hormone. This causes an increase in the serum calcium, as we mentioned, and then it provides feedback because we don't want to do it over. We don't want to overdo it. You don't ever want to overdo anything, right? So we're not going to just shut it off, and then this just prevents excessive secretion of any hormone because too much of anything is a bad thing, right? Obviously, there's our issues when we secrete way too much, so that's further down the line. But generally, everyone's got a good standing on this, right? I have no real questions in regards to negative feedback. And then just as a little reminder, our PTH, the PTH encourages calcium absorption in the GI tract, or as mentioned, we do calcium resorption. So resorption is not the same as absorption. You know, what's calcium depositing?
It's causing
Absorption.
Calcium, is that
You're building bones.
You're building bones.
Yeah. So you're putting calcium. Where are you putting calcium? I have all this calcium. Where am I going to put it?
In the bone.
In the bone.
Store it, right? You're gonna store it.
We're going to put it in the bone because that's what we need to do. But when we have too little, we need calcium in the blood now. We're going to go ahead and resorb. So we're taking it away. So big thing, that's like one big thing that I'm almost sure that will probably come up in the exams, is we need to really pay attention between absorption and resorption. Because absorption comes from the GI tract. Depositing means you're putting it in the bones. And resorption means you're taking it away from where you deposited. So pay very close attention to these words, because I've been doing that too. I've been reading questions too fast, and that's been screwing me over. And I know everyone's trying to hurry it up, but take it nice and easy and pay attention to what this is, because these little terms will screw us over, right? Okay, so we can move on to the next
So
one.
the
What's up?
resorption? Is
Yes.
that taken from away from bone?
Taking away from bone.
Taking away.
So again, what is absorption?
Is that like the GI tract absorb calcium
Yeah.
into the bones?
We're taking it from the GI tract. You're absorbing it from food, from chyme.
Mm-hmm.
Depositing, what does that mean?
Like adding it to bone? Like
Yes.
So that's absorbing?
We're depositing calcium as
depositing
cash.
it to bones?
Think of it as that. Calcium is cash. We're
Yeah.
depositing it into the
Bank.
bone bank, the bank.
Also, absorbing.
And then resorption means that you are
Take
Withdraw.
taking it away from the deposit. You're, I guess like pulling it back, you know, like you're removing from the deposit.
So you're breaking down bone?
You're breaking down bone. And it's done by the encouragement of your, yeah.
Okay.
So we can move on.
Let's go.
Oh,
Oh, sorry.
click out.
Okay.
Yeah, and then you, okay.
Yep.
So, we have our hormone pharmacotherapies, right? So typically hormones are used, obviously, for replacement therapy. Big thing. For replacement therapy, there typically should not be a lot of side effects, nor we don't have to change up the dosage. We don't have to alternate days, because all we're doing is just bringing the body back to normal. This is mainly given to people with Addison's disease. What is Addison's disease?
Yeah, decreasing your adrenal function, right? Your adrenal glands aren't producing.
Yeah. Hypo anything, menopause, because they're having lower function of their gonads, and then type 1 diabetes. These are all just replacement therapy. You should take these every day, obviously at their therapeutic rate. Now, you give high dosages, and those you do swap over you give it every 2 to 3 days. You don't give them consecutively, because high dosages, one thing that I think we can all agree on, or that everyone's noticed in physio especially, is that hormones will wreak havoc on your body. So too much of anything, I mean, we've seen it already with corticosteroids. They cause so many problems. So obviously, we want to just have our normal, because we're just bringing back the body to normal function. This is it. This is the only exception. But as for anti-neoplastics, those are things to prevent cancer, right? So it seems like you might have to give a higher dose for that.
Yeah.
But natural therapeutic effects, this just works off of replacement therapy.
Yeah.
It's just, again, you're trying to bring the body back to normal. But perhaps anti-neoplastics, the book didn't really clear too much on that, but I would imagine you need a lot of it to prevent it.
It said something about fighting breast cancer. So
Yeah,
you give a really high dose of testosterone.
Oh,
to
yes,
fight breast
that
cancer.
cancels out, because
Yeah.
now you're getting rid of what creates estrogen. What's causing the problem. So again, it's the same way too, if you have leukemia, you're overproducing a lot of white blood cells, if I recall right. So you want to take high levels of corticosteroids in order to shut down your immune system, which is...
Isn't that leukemia the immature white blood cells?
Well, it's overproduction regardless, because it's cancer. So again, you want to suppress you want to cause immunosuppression, which is one of the staples of our corticosteroids.
And this is the only time we give a high
dosages
to fight cancer
Mhm.
and to reduce some kind of crazy immune response.
Yeah. Also given for autoimmune diseases, lupus, arthritis. I'm sorry, rheumatoid arthritis. What's up?
Organ transplant?
Organ transplants as well. Those are given chronically to try to just drive down immune processing as much as possible, right? So this is where we could also have hormone blockers that inhibit it, right? So for instance, a little teaser for later, they're mainly used obviously for hyper whatever. We have a couple hormones for our adrenal gland, which is for our Cushing syndrome. We have ketoconazole and middlethane. So we'll talk about those a little later, but just think of these: azoles, conazole, and then middlethane and methimazole, right? So methimazole's for the thyroid. It's for hyperthyroidism. But one of the biggest things that you guys should just pay attention is that there's conazole or azole. It ends with azole. Those are big things. Always pay attention to suffixes. Now for middlethane, that one, unfortunately, it's just one of those that you probably just have to remember. I don't know if this one's connected to other suffixes, but at least for mazoles and your azoles and so ketoconazole, methimazole, they have similar endings, so they're going to do some kind of inhibiting of some sort. There's another one for hyperthyroidism, and it's a super long name with a P, and it ends with uracil. Pro something uracil. Again, those are just names that sometimes you might just have to learn on its own. But for the most part, that's it. So we can move on. Any questions here? No, we're pretty straightforward. It's like review. All we're doing is just really review. Okay. So as for here, right? So I would hope we don't have to remember every single little hormone of our body, right? But one of the biggest things to just help make things a little quicker is that the hypothalamus, the top part, right? The big one up here, that works hand in hand with the pituitary gland, right? We usually have the hypothalamus. You notice these R's? Or these I's, R's? So there's CRH, there's TRH, there's PIH. These are our releasing hormones. So think of this as like, I don't know, like the bullpen, right? There's pull and there's like the bulls. Like it's like the thing controlling the bullpen, right? So when you press the button, which is the hypothalamus going to work, this is the gate of the bull. The bull's in here. This is controlling that gate. We want to release that bull. So once it goes into the pituitary gland, you notice all these S's? So we have our S, another S right here, you know, like all those types of things. Anything with stimulating, stimulating, like our follicle stimulating hormone, our thyroid stimulating hormone, are coming from the bullpen, which is our pituitary gland.
So anterior, right?
Anterior. Most of the hormones are going to be coming from the anterior. The best part is that for posterior, we don't even. There's only two.
There's only two.
It's which ones? Without looking.
Oh, I already looked at them, so.
Yeah. Which ones are they?
ADH.
I already looked it up.
Uh-huh.
Okay. ADH. What's the other?
Oxytocin.
Oxytocin. That's the best part. There's any other thing that has like growth hormone again, and the best part is there's little hints. Growth hormone is very straightforward. It's just growth hormone. But then for up here, we would have growth hormone inhibiting hormone, so it stops it, or we would have growth hormone releasing hormone. So again, little hints from up here. They either release or they inhibit. Because again, what did our negative feedback, what does it reroute back to? It reroutes back to the hypothalamus. It tells our thalamus to stop. We're good. There's no more need for it. So if there's a stop of growth hormone, so this one starts secreting growth hormone inhibiting hormone, nothing comes out of here. But for whatever reason, if we need growth hormone, now we would have growth hormone releasing hormone, and it would tell our anterior pituitary, hey, release some growth hormone. And there we go. So again, to review very quickly, because we don't really need to go super crazy into this, what are the two biggest words that we need to pay attention to if it's coming from the hypothalamus?
Releasing or inhibiting?
Perfect. That's it. What about the pituitary? The bulb.
Stimulating. Or releasing. right?
Stimulating or no, releasing.
Sorry.
It's releasing. Right. That's it.
I have a mnemonic for the remember, you know the
Oh, you have a mnemonic to remember all these?
no, for the anterior pituitary?
Yes. Did you remember all these?
Yeah, it's a flat pig.
Flat pig.
Yeah, but you replace the I with the M.
Flat pig.
Okay.
Flat pig.
Write it down. Can you write it down?
Yeah.
And I'm gonna turn
Okay,
the camera.
I see it. Good. FLAT and P. Where's the I? Where's the P? PI. Where's the I?
Yeah. Where's that?
You said replace it with an M.
Yeah, it was.
Oh, flat mig.
Pumig.
Oh, pin. Oh, flat pin.
Pumigi. Pamji.
Oh, okay. So
Flat
just
pig, but
change
it's an
the
M.
I to M. Okay.
I see. That's a good one. I memorized it already because of flat pig. Yeah.
Yeah.
So what? It's follicle, luteinizing,
That's A is
ACTH.
Oh yeah, our
Okay.
adrenal cortical
no, it's
tropin.
ACT.
Yeah.
Okay.
Tropin.
T test.
Yeah.
Okay.
M is
Progesterone.
melanocyte stimulating hormone, but I don't think we're.
It's not
That'll be good.
Yeah.
Yeah.
Okay. Hey, I like that.
I like that too.
Yeah. Okay.
Flat. Here, I don't know if you guys want to be on this thing or not, so I'm just gonna, other people want to see it, right?
So that's our mnemonic to get down the different hormones that come out of the pituitary, both anterior and posterior.
Yeah.
Okay, cool. All right. Besides this, there's really not much else to go off of. As long as you make a very big emphasis on stimulating or releasing or inhibiting, stimulating.
Can you point out the MSHIH one? Because that's the only one that's kind of like weird. It's
MSHIM,
Yeah.
I feel like it has to do with melanocyte stimulating hormone.
it's just
Melanocyte stimulating hormone, inhibiting hormone.
yeah, that's the
So
only
again,
weird
it's-
one.
It's probably one of those that do both jobs.
Yeah.
Again, because
But we shouldn't be even going to that one anyway.
Well,
It's
yeah, I
just-
don't
it's just
know,
an odd one out.
yeah, the main ones that we have to pay attention to is ACTH, TSH, GH, not even PRL, we don't even do prolactin, FSH and LH mainly because of the gonads, and then oxytocin, probably, but ADH for sure we need to know. So that's it, so we can now move on to the next one. if you
The book goes into like menstrual cycle and
Yeah,
stuff
like
a
I
little
don't,
bit.
she doesn't really go into it herself that much, so.
Yeah, I hope not.
Yeah, I know, I hope not. So, again, as we mentioned, hypothalamus, it secretes, just like we said, all the releasing hormones, or inhibiting, but big one is releasing hormones. And again, all that negative feedback comes back to the
Hypothalamus.
hypothalamus. And it tells the pituitary to
Stop.
knock it off. Or, hey, do more, like one or the other, right? Again, we have posterior pituitary releasing hormone, the posterior pituitary that releases hormones, and those are two. We have our, which one? There's two of them.
The two of them, for the posterior,
Yeah, posterior.
ADH and oxytocin.
Yeah.
Yeah, there you go, straightforward.
Yeah.
Well, this is called the master gland, the pituitary gland, that's right. That one you just kind of have to know. I mean, there's not really another clear name or anything, but you can kind of tell how it's the master gland. It's the one that really initiates everything that happens. But when it's paired, do you guys know what it's called when the hypothalamus and the pituitary are like put together? They just call it like an organized unit. I forgot exactly, but the word unit is in the name. So they work as a unit because it's true. Without the hypothalamus, the pituitary can't do anything. And then obviously, if the hypothalamus is detecting some changes, but the pituitary doesn't work and it's not making the hormones, the stimulating hormones that we need, it's not going to get the satisfaction it needs to go back to homeostasis. Right? So again, it seems like these are going to be the ones that we pay attention to the most, right? Big ones. So we have our FSH, our luteinizing hormone, our antidiuretic hormone, and our thyroid stimulating hormone. So posterior pituitary, anterior, right? So in the event that she asks, I don't know if she will, but just in case, I came up with this way to remember what are the end products of follicle stimulating hormone and luteinizing hormone. So the way I did it is like a four-way box, right? So to remember the end products, because this is the final product. When we hear follicle stimulating hormone, we at least know these have to do with the gonads, right? When we think of a follicle, what is a male created thing from the gonads that has a follicle, a tail? What is it? Yeah. So we already have sperm down. So that's it. We're good. One. We're done. We already have a hint. Now we have luteinizing hormone. That's the other gonad-related hormone, right? What is the hormone that is dominant for men, that gives us our traits and all that? Testosterone. Okay, so now we've got these done, right? We're finished with those. My way to remember which one for women, it's estrogen or ovulation. When we have our testosterone established, which one has it? We crisscross for the other side. So now FSH is in charge of making estrogen. We just crisscross. What? Mainly going off of the dominant hormone of the gender or whatever. LH makes testosterone. So LH isn't going to make estrogen, FSH, LH isn't going to make estrogen. It's going to increase ovulation or encourage ovulation. So this is my way of remembering it. It's just like a crisscross method. I don't know if she'll ask about it, but just in case, it helps you understand what's going on.
Yeah,
Right.
for sure.
Yeah. So we'll review this a little later. And then as for thyroid stimulating hormone, it's just straightforward. And then our ADH. So we can move on. Any questions about this? No? Okay. We can go ahead and move on. Diabetes insipidus, right? So issues with the, without looking, because of what? What's going on with ADH?
I don't know.
Let's think about it this way. What is diabetes insipidus?
Is that Lucy, is it? ADH?
Pretty much, yes. But what's going on a little further? Without looking at here, what is going on when you don't make a lot of ADH?
Your name?
You're urinating way too much. And what happens when, because now you're urinating way too much, what could happen if you're losing way too much urine?
Thirst.
You're gonna have thirst. What's another thing?
Low blood pressure?
You could, because you're losing a lot of urine. But what's another big thing?
Electrolytes, right? That's the.
Like, yeah, there's gonna be our electrolytes, so we established that with insipidus, right? We're gonna have polyuria, right? We're gonna have, we can have low blood pressure, but again, what happens when you lose any kind of fluids? You're gonna get all dehydrated. You're gonna get thirsty, you have polydipsia, you're gonna try to drink as much water, but because you're creating so much urine, what is your urine mainly made out of? Water. So the specific gravity, which is a very important lab for our urine, is gonna be thrown off. Now, unfortunately, I don't necessarily know the exact ranges or labs, but all I know is that it's extremely diluted. Because the specific gravity, if I recall right, has to do a lot with the concentration of the urine. If you're making way too much water, it's diluted. In comparison to urine that's way too concentrated now, probably the specific gravity is huge. It gets more thicker. Think of how blood can get thicker with a lot of sugar, or things like that. It's kind of like that. So for this, what is do you guys recall anything that a med that helps us create more? Yeah. No. Not, we want to fix ADH. We don't want to make it worse. It's going to be oppressants. Oppressants. Pressin has a lot to do with the pituitary gland and specifically with that ADH. We have pressins. Notice these. Desmopressin, that DBAVP. We have lipressin, DIAPID. Diaped, or diapid. And then we have our vasopressin, which is our pitressin. Let me say it. So we could go on to the next one, but yeah, these are the big things: low blood pressure, electrolyte imbalance, and dehydration. So we can go ahead and move down. So big things that we want to know when we do any type of treatment for ADH, right? What are big things that we want to do, labs? What are big labs?
The specific gravity.
Specific gravity.
Inos.
Urinalysis. We don't want anything to cause, fluid intake and output. Avoid alcohol, because alcohol is a what?
Diuretic.
So if you take alcohol, one, not only is it with a med, if you take it with desmopressin or lipressin or vasopressin, what happens usually when you take alcohol with meds? It wreaks havoc on your body. So it's like all meds, pretty much. I don't even know if there is a med that's safe to take.
Yeah, right.
Yeah, it seems like every single one is bad with alcohol. So at least right now, this is a big one. But at least we know it also, not only will it mess with your body, it'll mess up your liver and all that, but it can cause you to urinate more, which is what you don't want to really do when you're trying to control your imbalance of ADH. Right? So we can now move on to the next one. Yeah. So this is a chart I made for diabetes insipidus. It's the best way that I can use to remember the durations and the durations of desmopressin, and then we have vasopressin and lipressin. So for me, the way I look at it is, it's kind of a dumb way, but I noticed there's 4 S's. That's kind of long. So it's the longest duration, long S. We said long ass. So long ass duration, which would be our 20 hours, which is the longest amount of time that desmopressin works. The nice thing about desmopressin is that it could be taken orally, or it could be taken nasally, or it could be taken by sub-Q or IV, for the most part. The cool thing about vasopressin, which is shorter, is our 2 to 8 hours of pressin, is that it's IM and IV. So again, for the most part, you just kind of have to memorize these. The way I at least know for like PO and nasal is like I picture just like the silhouette of a head, and it's like what are the only two routes really for giving these types of meds? So PO and nasal. So that's what I picture at least with desmopressin. Not the greatest tool I know, but it at least helps me kind of imagine. And then as for the SQ and the IV, again, you just kind of have to memorize them.
I mean, those are the only routes, right? I mean, there's no
They're
other.
the only routes, at least mentioned in the past slide.
Yeah.
Yeah, so-
QIB.
So one way I used to remember, this one's pretty easy, the DDAVP, right? Desmopressin, that was pretty quick with it. But one way I used to remember vasopressin's brand name is the vase has a pit. The vase has a pit for the flowers to rest in. I put a T in there, but rest in, so rest in. So when you put flowers in the vase, the flowers are resting in. Well, we're just gonna put a parenthesis in between the T and resting, so they're resting. So the vase has a pit for the flowers to rest in. So
Yeah.
yeah, just a way to remember the brand name. For Lepressin, I don't really have a good one. It's just kind of the shortest names because that's kind of with it. But not the best thing I know. But at least like it gives you something to kind of think about a little bit.
DDAVP has two Ds, there's two Ds in that.
Yeah.
Both Ds
So-
are at the beginning, I don't know, there's.
Two S's, two D's,
Yeah.
like two D's, maybe B in there. So,
Cool.
but yeah, labs, specific gravity, I know your analysis is mentioned, and low ADH production.
Like the durations, like those are long durations and shorter durations, right?
Yeah, so one thing to note though is
Like
that
the
before,
routes take long, right?
Yeah.
yeah, actually, no, yeah, because they take a little longer, yeah. That's a interesting, because this one, it's like
Oh, yeah.
faster,
Yes,
you know,
yes,
but,
yeah.
yeah, it's just, if it helps you, perfect. If I recall right though, Desmopressin, she did mention this, put it on the recent slide, go on the slide up.
Going up.
Yeah, so she did mention, oh wait, what the heck, one more? Oh, she did mention desmopressin again for short acting, so it could be possible that it works in both ways. But at least the biggest one to note is that desmopressin is the only one that can really do 20 hours, while our lepressin and our vasopressin can do the 2 to 8. So we can just scroll that back. Yeah. So you weren't here for it, Ian, but one way I used to remember the brand name for vasopressin is the vase, like a vase, picture a vase. The vase has a pit, for the flowers to rest in, so rest in, but we're just saying that the T's there, but it's resting. So whenever you put flowers in a vase, they rest in the vase, and it's a pit. So you put it in, so it's vasopressin. So the vase has a pit for the flowers to rest in.
Oh, you're trying to preserve.
Just so I can remember the brand names. Yeah.
Okay, you don't have to repeat it, because since we have recorded.
Still?
Yeah, thank you.
Yeah.
It's
No, it's
fine.
fine.
Yeah, thank you.
Okay.
Go up.
So thyroid, big thing, right? Hopefully we don't even remember the statistic. I don't think she's asking statistic
Yeah.
questions.
That's
Keep
crazy.
going. So, we have our thyroid gland, right? So this is something really, really important. The thyroid has two different functions. Unlike the parathyroid gland, the thyroid gland has two different functions because it has two different types of cells. One is in charge of calcium. The other one is in charge of metabolism. So our parafollicular, it's like a parafollicular hormone, which is what calcitonin is. It's two different cells, right? We have a follicular cell. I should have written this on here, but we have follicular cells that make T4 and T3. And then we have parafollicular cells that make calcitonin, which if you guys remember from the last exam, we had calcitonin in terms of like things like calcium control. So at least with this exam, it seems like it's a little bit more focused on the metabolism part of the thyroid, but it's still good to know, you know, to review that the thyroid also makes calcitonin, right? So again, just like a quick review, I guess don't look at the screen, don't look at it. Parafollicular cells make what kind of hormone? Calcitonin. And follicular makes
The thyroid,
T4, T3. So for me, the biggest way I use, again, sometimes they're not the greatest, but they help me. I think it's just more in the name, not on the purpose. Don't get it mixed with the purpose. But for me, parafollicular, I think of like, oh, it's kind of like somewhat like the parathyroid. What is the only purpose of the parathyroid? Calcium. Parafollicular, it's going to have to do something with calcium. Just don't push the boundary and realize like, oh, it increases our calcium serum, because it's actually calcitonin. The goal is to lower serum calcium by either depositing it in the bones, which increases bone density and lowers the risk of irreversible fractures, or by excreting it in the urine. So again, it's a little bit of a dangerous way to remember it, but as long as you kind of maybe test yourself a little bit, yeah, as long as you kind of test it a little bit, or you test yourself, you kind of could remember, okay, this one's for calcitonin, the parafollicular cells make calcitonin, follicular cells make with T4, T3. No question on that?
So the function of calcitonin is
It's to lower serum calcium levels by either depositing in the bone or excreting it in the urine. Yeah. And I mean, this one's straightforward, it's just on metabolism, so we can move on to no other questions. So thyroid gland, big thing that's, as mentioned, it's repeated again, so that's super important. It has to do with metabolism. This is going to be important too. When a person has issues with their thyroid, they need to have it monitored every month, initially. Like, let's say if someone has like a new onset of hypothyroidism or hyperthyroidism, they need to have it checked every month. Now, if they've been dealing with it for a year or two, then you could check it quarterly. So quarterly means obviously 4 times a year instead of 12 times a year. So it just varies. It also depends on what the provider's going to say. So we go ahead and move on. And this just reviews the feedback. So, hypothyroidism has a weird disease name, myxedema. Kind of a weird name. Yeah. Unlike hyperthyroidism, kind of has something a little bit more like, what do you call it, Graves' disease. That one sounds a little bit more like, oh, okay, I can kind of get around that. It's just called myxedema, or myxedema, or whatever the heck. So for the most part, hypothyroidism, don't even look at this, right? So metabolism, hypothyroidism. What's happening to our metabolism when we're not making a lot of thyroid? It's pretty much going down. So what happens to our heart rate?
It's going down.
What happens to our sensation of cold? You become more intolerant to cold. One of the biggest driving forces for the stimulation of thyroid hormone is the cold. Because the cold makes our body, like we're going to shiver, right? So we need heat. What's a way to generate heat? Increase metabolism. You're going to increase your heart rate. You're going to increase your body temperature. You're going to increase things in your body to make you kind of get warmer, right? So in this case, if you're having hypothyroidism, so you're not making thyroid hormone, everything's all slow, which is very nice because they coincide with each other. We have the slow metabolism, which makes you intolerant to the cold, decreased sense of smell, and the way we could look at it is like, again, you're having, everything's lower, even your CNS system. This has a lot to do with our central nervous system. So we're super low, you know, so that could alter your smell. And then speech, bradycardia, weight gain. Again, we're having no metabolism. You're retaining all the things you eat, so you're gonna gain more weight. You're not burning it off. And then, big thing to know, whenever, kind of think about it a little bit, right? So there's a problem with an organ somewhere, right? Endocrine organ. Up here is working normal. It's noticing something's wrong. Hey, we're not making thyroid hormone. Could it be possible that the thyroid isn't getting the message? What is our message from up here? You don't have to use the hypothalamus, just the pituitary. What is the message made by the pituitary hormone that the body thinks that the thyroid isn't getting? TSH. So, as a panic thing that our body's doing, it's creating more TSH. But because we're having low levels, it thinks that it's not getting the message, when in reality, the body doesn't know, but in reality, the thyroid is having an issue. This is something very important for all the hormones. Same thing with our adrenal glands. If you have primary adrenal insufficiency, you're typically going to have high levels of ACTH, but low levels of corticosteroid production. Because again, the body's freaking out. It's thinking, hey, there's something wrong. Maybe it's not getting the message. We have to make more of that message to get there. Maybe if we make more, some will be made, but there's a problem. Obviously, the body doesn't know, so it can't really work around that. But that's one of the biggest things that's super important. If there is ever a hypo anything, always route back and realize in your labs, they're going to have high labs of the stimulating hormone of whatever it is with diminished end product. You're not going to have a lot of it. So we're going to pretty straightforward now.
Yeah, very straightforward.
Yeah. So again, biggest cause of the hypothyroidism is the autoimmune disease, Hashimoto's disease, which is thyroiditis. It kills it. You're done. I'm able to just easily remember this. It's just Hashimoto. It's like the only one that has kind of like the more Asian sounding name, like Japanese, whatever. And like, it's just cutting off the thyroid, just like cuts it off, stuff like that. So,
Yeah.
I mean, not to be insensitive, but it's the best way to remember.
So
Like,
Pink Samurai, cut the Pink Samurai.
I didn't grow up this, but now I do.
Yeah.
Makes sense.
It
Now.
makes sense,
Yeah.
right?
Yeah,
I got you, yeah.
Hey,
So
so
it's-
pass the test, boys.
yeah, it's past the test. I think we could overlook that a little bit. But in the most respectful way, you're just cutting off the thyroid.
That's good. I didn't make it so nice.
Autoimmune.
Yeah.
Autoimmune.
Autoimmune, you're cutting off. It's your own body.
Yeah.
Getting rid of it. I mean, little things like that make you remember. So.
It does.
So what did we mention already? High levels of thyroid stimulating hormone, and that is because
The
decreased levels. So again, what is the process behind that? What's going on? What is the body thinking?
It's like negative feedback, right?
Not necessarily negative feedback. It's having a panic mode, because if it was negative feedback, everything would be on normal, right? Because then they would stop making TSH, because T4 and T3 would be made. But in this case, it thinks that the thyroid isn't getting the message, so they have to make more of the message to get it to work.
It's the opposite. It's the opposite of the negative feedback.
It basically, hell, you can kind of say it's kind of like a positive feedback.
Yeah.
Because remember, oxytocin, the most constantly used reminder for it, or example, is childbirth. As the child is going through the vaginal canal, it's inciting the hypothalamus to create oxytocin, which oxytocin encourages cramping to push out, the kid. So as the kid's being pushed out, it's triggering it. So it's just making more of the message. This is basically kind of, I guess in a sense, to be a little loose with it, like a positive feedback. It's panicking. It's like, why isn't this being made? Maybe it's not getting this. So make a shit ton of this, so this can start being made, and we can all go back to normal. But again, unfortunately, it doesn't work out that way. So, usual treatments. We have our thyroxine, which is our normal human-made thyroid hormone. We just have levothyroxine. That's pretty much it. Synthroid is like the big brand name. Usually they have throid in the name because it's for the thyroid.
Yeah, they're kind of givens, right?
Yeah, and as mentioned, oh yeah, and levothyroxine, because it's a thyroxine, it's T4, right? It's T4. T3 is going to be its, that
Metabolized
triolo, whatever. Yeah, big thing. Ian, I don't know if they asked for this, and Jonathan as well. You guys maybe not have seen through it, but thyroxine T4 is metabolized or broken down into T3. So it's like, you'll have T4, right? But T3, just like how vitamin D has
That's a precursor.
like a precursor, and you know how the active form of vitamin D, what is it called? Calcitriol.
Yeah.
That's kind of like, this is vitamin D, and then T3 is the calcitriol.
Yeah.
It's the active form of this. So it gets kind of broken down a little bit, and then it just, so this will eventually turn into T3, which will be used by the body to make.
To be absorbed, yeah, to be absorbed by your, yeah.
Yeah, to make thyroid hormone. Pretty straightforward. Any questions? Okay, we can move on.
Everybody, hang on, do you need a break or anything before we keep going? Does
No.
anybody need a break? We're all good?
I'm all right.
You good?
Yeah. It was good.
Yeah, let's go ahead.
So,
Perfect, Professor.
so pretty much, we have our thyroid agents, right? As mentioned, Synthroid. So pretty straightforward. Hopefully she doesn't throw like, hey, what are 5 other brands? I'm like, please don't ask for that. Because that's for the most generic one, like, or the brands, right? So, mechanism of action, again, it's synthetic thyroid hormone. It's just straightforward. Primary use, bring us back to normal. Bring us back to that normal metabolism. It's replacement therapy for patients with low thyroid. It's straightforward. There's a reason why I've been highlighting it. It's just, it's pretty straightforward. The interesting thing though, for all different types of treatments of all hormones, the adverse effects are pretty much what happens opposite of what hypo whatever is. So if you give way too much of levothyroxine, what can happen? Now you're not hypothyroid, you're hyperthyroid. So now you're having the high heart rate, you're having the dysrhythmias, you're having the high intolerance of heat because your body's making too much. Like it's just metabolizing too much. You're losing weight. In women, you get menstrual irregularities. Your body's just out of whack. You get anxiety. You sweat more. You're just working off. So again, oh yeah, let's see. Menstrual irregularities and osteoporosis. And again, the osteoporosis means we have low levels of calcium in the blood because it's using too much calcium. Remember, that's very important for muscle contraction. We need calcium at the ready in order to move them, contract the muscles because again, what's working really hard to do all that job? The heart, muscles are moving, everything's working that's out of whack. So for the biggest part, we need to have these things that the body needs to have it. This isn't good, but just always keep in mind that the adverse effects for whatever hormone treatment is typically the opposite of like if it's hyper or hypo. Right? So adverse effects of levothyroxine, what are they?
Hyperthyroidism.
Pretty much hyperthyroidism. All the signs and symptoms of hyperthyroidism. That's it. Yeah, that's like
Cool.
that straightforward. So I highlighted the biggest things that are very important. It takes about 1 to 3 weeks for thyroid drugs to really take effect. Again, as mentioned, actions again, it's just straightforward. What could happen? Loss of weight, improved tolerance of heat temperature, it's just talking about what happens with it at normal levels. You know, to avoid adverse effects, dosage are highly individualized, as mentioned, because we're doing replacement therapy. We're not doing immunosuppressant therapy, we're just doing replacement. So it's gonna be tailored to the body, it's gonna be to the weight, to whatever you have. But that's one thing that's very important, 1 to 3 weeks. Always remember that, it takes 1 to 3 weeks. It might not be as effective immediately, but as soon as you take it, give it some time, it'll work. And then, as mentioned, big thing, for one thing that we've noticed on all our drugs that can have an effect on the heart, or the vessels, or how blood flows and everything, what kind of precaution do we want to take when we are giving those types of drugs for people that have heart issues or blood circulation issues? Because, yeah, we want to take precaution, right?
Oh, people with cardiovascular disease?
People with cardiovascular, because what is going on with levothyroxine that makes it, you want to be very careful with your heart.
It increases the heart rate.
You're increasing the heart rate, you run a risk of causing heart failure, because if you go overboard or whatever freak accident, your body's working even harder, and if your heart's already not at the best condition, it's just gonna make it poop out. And then now you have a bigger problem going on. So that's why patients with pre-existing cardiac diseases, they kind of need to take it a little bit easier. And then also remember what we mentioned on the last slide, they cause dysrhythmias. Do you want a dysrhythmia when you're having a heart issue? No. So it's just gonna make it worse. You're gonna freaking tank. So that's why it's very important to just take that as a precaution. It's something very good. So we can go ahead and move on to the next slide. It's pretty straightforward. So the nice thing about this is that it is a Category A drug for pregnancies. Category A. That means it is safe completely for women. There's Category A, there's B, C, D, and X. X is completely contraindicated. You should not have, for 100%, do not take it. A is, hey, this is completely safe. B is, there's no evidence in animals of getting, like pregnant animals having issues, but there's not enough studies for humans. And then C is, there is documented evidence of damage in animals. But again, there's not a lot of, studies on humans. And then D is, there is a straight up documented, like it has injured humans.
Damage?
Yeah, like risk, like damage to the fetus. So that's something very important to know. I mean, for the most part, thankfully these haven't come up.
Yeah, right?
Let's hope they don't more, because it's just extra stuff that we have to learn. I mean, it's important to know.
Was it methimazole, right? Is category D, right?
Yeah, category D, at least in the book.
Yeah.
But methimazole is like really bad for, so let's just think about it this way though, like it's a synthetic thyroid hormone, right? And we're taking it normal. You need thyroid hormone in order to work the body. I mean, if you're pregnant too, you have a kid in you. You're eating for two, you're living for two and everything. You need that thyroid to work as normal.
Yep.
And again, it's just a synthetic version of the hormone that the body makes regularly. It's safe because that's what the body needs. So there's not a lot of risk. Just the big thing is that this one, for levothyroxine, you do not take with food.
Oh, you don't?
Yeah, you don't take with food. You leave food out with levothyroxine for a minimum of about 30 minutes to an hour.
It causes GI irritation? That's
No,
one of those?
it's to lessen issues with absorption. Because if you take it with food, food can mess with the absorption of levothyroxine. Same thing with methimazole or tapazole, brand name. Anything relating to the thyroid, you do not take with food. So my biggest way of remembering is that you leave food out of levothyroxine. You leave food out of levothyroxine. Yeah. Because
That's good.
for a minimum of 30 to an hour, because you don't wanna mess with the absorption rate. This is a vital medication in order to get you to work back to normal. So you don't wanna mess with the absorption. So we can keep it on. Adverse effects, as mentioned, in therapeutic doses, very rare, but avoid overtreatment, like we mentioned, and it's talking about this, so it's talking about like the side effects of hyperthyroidism, the palpitations, dysrhythmia, anxiety, and all this. What did we establish already? The adverse effects of any hormone medication is the opposite
Okay.
signs and symptoms of whatever it is. So again, if we have hyperthyroidism, to like kind of work a little further, if we have hyperthyroidism, what med are we going to take?
Methimazole.
Yeah, methimazole. If methimazole works a little too well, now what signs and symptoms are we going to have? Well, side effects. Hypothyroidism, it worked too well, so now you're having the opposite effect. So that's why these are like super important to know the dosages. Well, not know the dosages, but just be aware that all the dosages are tailored to the patient.
Specific.
Yeah, they're very specific because they can vary, weight or height or whatever the heck. So now we can move on. Big things that are important, contraindications. Obviously, like always, if they're allergic to it. And you know what? And that sucks. Like, imagine being allergic to
The
a
best
hormone, then it's like, damn, then how are you going to function? I don't know. I mean, they probably find a workaround, right? Do you want to give more to a patient that already has a lot? Thyroid toxosis? No. Clear indications. It's just straight up. But, what did we talk about earlier? You want to be careful when they have severe cardiovascular conditions or acute MI. You don't give it to them for that. And then you could also, we'll get into this in a little bit, but again, just to review, why don't we want to give this? Like, I mean, not in this one, because these are straight up like contraindications, but like, well, at least with someone with like more of a history of like heart disease or heart failure, or like, you know, it's getting there. Like, why do we not want to give thyroid, you know, medications? Be very careful with our thyroid medications. Why? Why do we want to be?
Dysrhythmia, you can cause.
You're gonna overwork the heart.
Yeah,
Overwork the heart.
we're gonna make your heart overwork, and then
And then you end up with the acute MI.
yeah, and then yeah, you end up in the acute MI or something. Yeah, so yeah. We'll take a quick little break.
Oh, yeah.
Pause it real quick.
Yeah.
So just like a quick reminder too, right? So our body's metabolizing more, right? We need more energy. What is energy in our body?
Glucose.
So when you have when you're having, you know, like another contraindication, or not contraindication, sorry, something just to notice is that if the patient has diabetes, right, or some kind of hyperglycemia kind of thing, right, and your body is already working on this, and it's having high levels of sugar in the blood because of the increased work, you're going to need to adjust your dosages for insulin.
Oh, okay.
Yeah.
That makes sense. Okay.
Yeah, so it's all like it's like a domino.
Yes.
Yeah. So it's kind of like starting to think, okay, well, our body's working harder. It needs more sugar. If they have diabetes, they're going to need more insulin. They need a dosage adjustment because, you know, they're having hypothyroidism, so you're giving them a drug that's going to bring them back to normal. You need to adjust the dosage.
Yeah.
Oh yeah, and then the black box warning. The black box warning, if I recall right too, is about the severe like cardiovascular issues and acute MI. But the other black box warning is that you probably should not use levothyroxine to lose weight.
That's
Because that's not
Ozempic,
healthy.
not levothyroxine.
No. Ozempic is its own different. That's its own different monster. So it's like, yeah.
I'm gonna grab a bite real quick.
Yeah, Alright, so we've established some things about levothyroxine. Now I believe we are on the last page. So interactions, drug interactions. Typically, there's going to be a couple considerations. So first one, anything that has, it sounds like it's like coal, like anything for the colon. And we're gonna find that out right now with herbal and food.
Mm-hmm.
But anything with coal, so like for instance, cholestyramine, cholestyramine, and cholesterol, they decrease the absorption rate of levothyroxine. In addition, they'll be taking food, but we're leaving it out of food. But those sound like they have to do a lot with the colon, which usually they do. That's why they have it in their name, the colon. It's a big name. So that's something very important. Another thing too, when we have epinephrine, like levels of epinephrine, like taking medication like epinephrine and norepinephrine for whatever reason is required, that can cause right back to the heart issues, the heart failure, or the cardiovascular disease. As mentioned right here, concurrent administration of epinephrine and norepinephrine increases the risk of cardiac insufficiency. Do we know why? Why that drug interaction happens?
They increase the heart rate?
Because you're increasing the heart rate, and when you increase the heart rate with levothyroxine, if you're having too much of it or whatever, you're having like signs and symptoms of hyperthyroidism. Your heart's working like fast, right?
Yeah.
What can that cause? When your heart's beating way too fast, what sometimes happens occasionally?
Ventricular or something?
That's, think broader, because that is one. Think broader. It's a dysarrhythmia. You can have dysarrhythmias. Yeah. The VTAC is just a type of dysarrhythmia. The same way how VFib is, how like a PAC, a PJC, and PVC, those are all different types of dysarrhythmias because it's just a flaw in the rhythm, which is what can cause, cardiac insufficiency. It could put you to shock or something, like something of that sort, cause an MI. And then with warfarin, same thing. One thing that I'm really noticing a lot with all these different medications is that warfarin has a lot of interactions with a lot of different drugs. Like for instance, when we did acetaminophen, warfarin affects, or warfarin has a messed up effect where it's like the liver obviously metabolizes drugs, as we know, right? It seems like the liver will prioritize drugs that are a little bit more dangerous, I guess. Or not really dangerous, but like they take more work, So it seems like for acetaminophen, because it is hepatotoxic, right? It'll prioritize the acetaminophen. We want to get rid of this. We don't want to have this a lot because we want to minimize as much damage as possible. It could probably be the same case with levothyroxine. Now, I'm not entirely sure if it's hepatotoxic, but one of the big things that is pretty important to note is that it will prioritize that over warfarin. What did we know from our pharmacokinetics chapter? What happens if a drug is left in circulation for long periods of time that it's supposed to be metabolized? What can happen? Toxicity. So you can have toxicity, especially if the patient keeps taking the warfarin as directed by the doctor, and they're taking levothyroxine. That can cause an issue, and now you have an increase of toxicity, or increased risk of toxicity, and you have an increased risk of bleeding because warfarin is a blood thinner. So that is just something additional. So 3 major things taking point with drug-drug interactions of levothyroxine.
Stay in your body longer.
So that's for warfarin, yeah. And then the epinephrine and the norepinephrine will cause heart issues, like the heart.
It's adrenaline, right?
Yeah, it's just straight adrenaline. But again, you're with levothyroxine, you're already working harder, and then now you give them another drug that just piggybacked off of it, and it's making them work even more harder. And then the cholestyramine and cholesterol, they sound like colon, so they have.
Something to do with like cholesterol.
It's cholesterol, but like it goes through your GI tract.
It just sounds like GI tract. That's the first thing I think. Colon.
It is.
Yeah.
But they're associated with cholesterol.
Wait. You know what? That kind of makes a little bit more sense, right? Because this is a hormone. Hormones can either be made out of water
or fat.
or lipids.
Oh, okay,
right? So if this, because I haven't looked into it, so I'm sorry about
Yeah.
that, but
No,
I haven't
you're
looked
cool.
into these. But if they really are referring to cholesterol, that makes perfect sense, because if actually look it up right now, is
Yeah.
levothyroxine a lipid-based hormone?
Let's find out.
Because if it is, then this makes so much sense why it decreases absorption, because if these drugs decrease absorption of lipids, then you're gonna have an issue getting levothyroxine, because it would also be a lipid, but we gotta confirm that. Rather than say-
Synthetic.
Synthetic version. Yeah.
Oh,
it's
wait,
just
what
like-
about thyroxine?
Oh, hormones are lipid based.
Or water?
Oh, you know what? They
Or-
Is it lipid soluble? Yeah, it's a lipid soluble hormone. And then, right, so cholestyramine and
I think it's
cholesterol.
lipid too, because it's cholesterol.
They have, yeah, they have to do
Okay,
something with
let's,
cholesterol.
oh, yeah, water soluble, lipid soluble.
The higher
Really?
and bulk buffer with cholesterol. I mean, we're getting off topic. This is-
Yeah, yeah.
That's what I'm talking.
Doesn't matter.
Oh,
Well, we're talking about these meds right here and how they interact and why they interact, you know?
Oh, well, that, you know what, I mean, it makes sense, thyroid hormone is considered a lipid soluble, so it's gonna fall under the same rules as
Yeah,
that,
and
so.
it would lower cholesterol, say.
Yeah, so this will just beat it, even better, now we have a
Yeah.
better understanding,
Yeah.
like, yeah, because cholesterol, the cholesterol levels.
Yeah.
Okay, sweet. Okay, so as mentioned, lab tests, there's not really a lot of lab tests per se, but as mentioned, yeah, like what do we know at least that we need to check? Thyroid stimulating hormone, we need to know T4, we know T3. Those are the big ones, really. Like, yeah, there's no lab tests that we really need to be worried about, but at least those for sure.
For sure.
You know? And then as mentioned, always our UN, our CK, and then our friggin' ALT, AST, as always, because every single drug you should always watch out for.
Messes
the
with your
liver.
renal function, messes with your liver.
Yeah. As for treatment of overdose,
Oh, yeah.
there isn't really a treatment per se, but the best thing you could probably do is that if a person is under toxicity of, thyroid toxosis or whatever, thyroidotoxosis or however you say it, the best way to prevent the cardiac toxicity, because again, the heart's beating so much, you need to put them on you need to put them on a beta blocker, the propranolol. Yeah, like your beta blockers, your allols, those are beta blockers, basically. And we'll get into that like weeks later,
Yeah.
when the fucking difficulty spike is gonna jump like crazy. So, now we're gonna spit out everything we learned right here on there.
Okay.
So,
You guys wanna keep recording or you guys wanna just go off?
up to you, yeah. Well, or actually, yeah, just pause it. Yeah.
Pause it? Okay.
So, we can go ahead and revert back to, oh yeah. So take calcium, iron supplements 4 hours after taking levothyroxine, like all meds, regarding that. So big thing to always remember. If I do recall right, it was alendronate. That was also take 4 hours, because that one is preventing osteoporosis, right? So you also want additional calcium intake.
Yeah.
Because-
it was the.
And then to kind of revert
Steroid,
back
right?
to alendronate, right? Your body is refusing to use alkaline phosphatase to break down, which prevents the osteoclasts from taking calcium to the bones, right? So now that there's no calcium going into blood, you could be hypocalcemic. So you need to take, no, you don't need to take that. You just need to take calcium supplements, because you're not getting your supply anymore from the bones. So if you don't get it from the bones, where else can you get it from?
What you eat?
Your GI tract. Yeah. Just recall that. Okay, so hyperthyroidism, Graves' disease, right? I was told that with hyperthyroidism, can lead you to the grave. I don't know, that's like kind of the way to think about it, all right? Biggest thing to note about hyperthyroidism, right? It's what we talked about in terms of side effects of taking medications like with levothyroxine, right? So, as mentioned, but this just goes a little further into it, right? So we have exophthalmos, right? So that means your eyes are bulging. The big way that I use to remember that is the body's working so hard, your eyes might pop out. You know, because it's like your body's working hard, you have an increase in pressure because your heart rate is working harder. Your heart is working harder. You know, you're doing so much. So your eyes are going to start kind of popping out a little bit. Right? That's one of the biggest things about Graves' disease. Weight loss, we already established that. Your body's working hard, you're having higher metabolism, you're burning more food, you're burning more fat, you're getting rid of weight. Goiter can happen, you guys know what goiter is?
Don't you like iodine?
It's like swelling
Yeah.
in your thyroid gland. That can happen with both hyper and hypothyroidism, but mainly it's found in hyperthyroidism, which is kind of interesting. Obviously, the biggest goal for hyperthyroid treatment is to lower the level. It's as straightforward as that. So, from here, biggest thing to be careful though is thyroid storms. Now, the thyroid storms are like the most extreme side effects that we talked about when we covered levothyroxine. So, as mentioned, we would have the shortness of breath, you know, because again, it starts happening. We have higher anxiety, heart failure occurs. Disorientation is going to just come hand in hand when your body's starting to tank. But this one, instead of you having higher levels of sugar, that you need to increase your insulin intake for the drug, you work so hard that you ran out of sugar in the storm. You know, because your body took so much energy. You're in a thyroid storm. Your body's working crazy hard. You're starting to have more dysarrhythmias with the tachycardia. You know, you're having hyperthermia because your body's working way too hard. You're hot. Your chest pain is now coming because of the palpitations and the heart rate. And then you're sweating because that always just kind of comes hand in hand with palpitations and all that. Weakness. You're not going to do 3 backflips back to back. The heart failure will come if you don't get that treated, and then you'll just die. And the anxiety, shortness of breath, and disorientation, all these 3 symptoms go hand in hand when you are having crazy anxiety related to any kind of condition. Okay, so pretty straightforward, you know what I'm saying, you know? Here, just extra reminder, you get hypoglycemia, disarrhythmia, anxiety. So, cool. Go ahead and scroll down. Everything clear right here?
The slide about that.
Want to go one up?
Yeah, there.
What about it?
Is it only calcium that you take for
What?
4 hours after?
Calcium and iron, right?
Iron too?
Yeah. Honestly, I guess rule of thumb is any kind of supplement medication. Well, not medication, but like supplements, your calcium, your vitamins, your iron, your whatever. You take it 4 hours just because you want to have it absorb well. But the main thing is that what we're focusing on is it's hyperthyroid. It's relating to the thyroid. So we're talking about calcium more than anything, and then iron as well. What was it? Was it iron that encourages, or was that vitamin C? No, vitamin C encourages absorption of iron. Sorry, I'm just kind of thinking of it. Or it's vice versa. Where it's iron that encourages. No, it's vitamin C that encourages iron. But it's okay. We don't really need to get into that. In 2 weeks, next week, because that one we cover vitamins. So.
You know, it's a basal metabolic rate.
What's up?
Basal metabolic rate.
It's a base, right? It's here.
Yeah, isn't it like
I think
or in the
like
morning?
I think it's the amount of energy you need for like you use
Resting.
When you're resting.
Oh yeah. Like so when you're just laying down, like your body's using that to the energy you need just to lie down.
Yeah, for the
To exist.
Yeah.
Right? Just to exist. That's basically what it is. It's just you for
I think
existing.
it's what we're talking about for the metabolism.
You want me to go back?
Maybe. I don't think I mentioned it.
Where? Right here, or keep going up?
We can continue on.
Yeah, well, okay.
Just keep going?
Alright, so symptoms of hypothyroidism. We already talked about it. Increased body metabolism, tachycardia, weight loss. There's going to be muscle weakness. Now, the best way I think of it is like muscles get tired of working so hard. That's it. You're just getting weaker.
Yeah.
Yeah. Probably hypothyroidism, you can maybe get some cramps because now you're having possibly lower levels of calcium. It's possible, it's not always, but with like, hypocalcium. Well, then again, also.
Are you talking about muscle weakness or tremors?
Like the tremor, so like,
That's
one thing
what-
that's noticed is like with hypocalcemia, you get the seizure, well, that's extreme, but you get the cramps, it's like anything with conductivity.
Electricity, yeah.
It's just like, I was thinking too, it's like, because I looked it up, hypothyroidism could lead to muscle cramping because of hypocalcemia, but again, it's like, the thyroid is more, the calcitonin is more for either depositing or excreting, it's not really about, it's getting rid of calcium in the, oh, you know what? Kind of a weird rabbit hole to get into, but I mean, long story short, just kind of think about that. So we already got the elevated temperature, the anxiety, nervous system tremors are all hand in hand. This is the body temperature going up, which means heat, fever, excessive sweating. So all these are color coded because they work off of each other. That's it. We just, with no questions, we just got to move on. So treatment. So we checked it out too. We recall that Professor Huang said that usually the first type of treatment is cutting a little bit of the thyroid, a little bit. It's called ablation. Ablation, that's what it's called. And it's just cut a little bit of it. Usually, hand in hand, radioactive iodide, 131, is also used. But this is kind of careful, you need to be very careful because obviously the main goal is to destroy only a part, so it needs to be tailored, but sometimes it can work a little too well and it can kill the entire thyroid, which you were treating hyperthyroidism and now you just killed the thyroid. So now you have hypothyroidism. Sometimes it's straightforward. Other medications, as we mentioned, the propionyluracil, whatever the hell. It's a pretty noticeable name. I at least recognize the name. I haven't looked up the brand name, but hopefully she won't just use generic. But yeah, I mean, it's a pretty recognizable name in terms of like treatment of hypothyroidism. And then this is one of our med cards, the methimazole, tapazole. These medications should be avoided with pregnancy and breastfeeding because this can hinder the child's growth. If you think about it.
Yeah.
Again, you're hindering the thyroid from working. And also, it's probably fucking toxic. This drug is bad. Like, I swear, methimazole, like, you guys saw in the med card, like, it does like a bunch of things. It's hepatotoxic, I think. You need to have, and then I think you also need to have like CBC and like WC, like monitoring too. This drug is pretty bad. Like, it does some pretty bad stuff. So, obviously, you probably wouldn't want to take it. So, category D from the book.
Yeah, category D.
Any questions regarding this? Okay, we can move on. So, the role of the nurse when it comes to thyroid treatment, right? Or therapy, whatever. Impaired renal function. We always do that. That's like always what's done.
The renal function?
Yeah,
Like the creatine,
BUN and your CPK.
CBK.
Or I'm sorry, CKP. CKP. The
Creatinine,
kinase,
and your phosphate, or what?
I thought it was like something. I don't know. I thought it was CKP or something. It's CK and CKP, but. Oh yeah, and it usually indicates damage to the heart, brain, and the skeletal muscles. Yeah, so like that. I would imagine also the freaking kidneys and stuff. So, monitor basically for hypothyroidism. The fatigue, the slow speech, the hoarseness, the slow pulse. And then monitor the patient's weight because again, high levels or low levels of thyroid hormone influence weight. And did we establish what was the weight window? Did you say it was 5 or 10 pounds? Like if the patient.
I think that was a different drug, not this one. We didn't establish a weight.
I thought we did. What was that drug for? Or the weight for that drug for?
It was one of the corticosteroids.
Oh, okay.
It was like
But you said it was
2
like,
pounds in a day and 5 in a week, something for the corticosteroids.
and that's really bad.
That's
two
bad,
pounds in
yeah.
a day, 5 in a week. Okay, that makes sense. And then it says tachycardia, regular heart rate, hypertension, it's a sign of symptoms of hyperthyroidism. So pretty straightforward, no questions here? Move on. Patients receiving anti-thyroid therapy. Always we grab health history. We always do a physical exam. We always do labs. Take the medications consistently. That's something that we know. As mentioned, take on an empty stomach prior to breakfast. Is he referring to the methimazole and the freaking Uracil, that one long name that you like recognize that, oh, this is for hyperthyroid. And it's also for thyroid therapy. So again, like we established, anything regarding food and anything with thyroidism, whether it's high or low, you leave food out. So you leave food out of levothyroxine for 30 to 60 minutes and then you can eat. And then you also leave food out for methimazole. So anything regarding the thyroid, you do not eat food with it because you don't want to hinder its absorption. Yeah. All right, let's bring it. Now we're into the adrenal glands. So adrenal glands, we can kind of move up a little bit. So biggest thing right here, right? So as mentioned, we have our hypothalamus that creates CRF, which is this right here, right? Ignore this part. CRF, and it's going to tell the anterior pituitary to create ACTH, which the ACTH will then go to the adrenal cortex and tell the cortex to make glucocorticoids, mineral corticoids, and gonadotropins.
Cortex is the shell, it's not the
Yeah,
medulla, right?
so again, yeah. So we have the cortex, and there's the medulla.
It's the outside part.
Yeah, it's the outside. What does the medulla make for the adrenal glands?
That's your epi-norepi.
Epinephrine
Oh,
and
I
norepinephrine.
forgot. Yeah,
Yeah.
that's huge.
So our the internal portion, the medulla, the middle, makes epinephrine and norepinephrine. Which the way I used to remember it is like, think about it, it's like, do you want epinephrine to just leave out of there, like all the time? No, because you're always going to be on, and like you're going to be super anxiety, like having high anxiety and all these different things, and so on and so forth, and like your freaking veins are going to constrict, and your blood pressure is going to skyrocket, and your heart rate's going to skyrocket too, and then your heart's going to blow out of your chest and all that crap. So what you want is to keep that inside and only let it come out in the most dangerous situations, like our fight or flight, which is more stimulated from the CNS and our autonomic nervous system. But we do want to have it more on the outside. We want to have our corticosteroids on the outside because we want that to come out whenever we need it. Very important because, again, this helps us out with sugar metabolism. It could also it's gluconeogenesis?
Gluconeogenesis.
Yeah, gluconeogenesis, which creates sugar out of lipids and proteins. That's why your sugar goes so high when you're taking, especially like these high levels of corticosteroids for immune suppression or something. Mm-hmm. Obviously, that's not going to happen if you're taking it at a therapeutic level. But if you're doing it because you want to inhibit the immune system from attacking your own body, or an organ transplant, or some kind of cerebral edema or something, you're going to do it that way more with that. So, big thing to notice. That's why the sugar's so high. And again, just like levothyroxine, who diabetics need to adjust their dosage, you also need to adjust your dosage when taking corticosteroids. So we established that glucocorticoids, it's in the name, glucose, have a lot to do with the metabolism of sugar and creation of the gluconeogenesis and all that. But now we have mineral corticoids, and our biggest one is aldosterone. Aldosterone, do you guys recall what aldosterone is? I mean, it says it right in the name, but typically, like, it just helps you, yeah. So it helps you reabsorb water And there it is, potassium secretion, right? So typically this can lead to high levels of blood pressure. Organocorticoids, they don't really come up a lot. She doesn't really mention it by the look of it, but just for note,
Is aldosterone, isn't it ADH? Is it ADH?
no, they work hand in hand with ADH.
Well, it's
Because,
a diuretic.
because-
That's a diuretic. No.
no,
No.
not necessarily, because this increases sodium reabsorption. Do diuretics cause sodium reabsorption?
No,
You get rid of it. Yeah. So aldosterone is gonna be big for next week, because it has a lot to do with ROS, which is our renin angiotensin aldosterone system that works hand in hand with this. And we can talk about that later. At least with gonadotropins, just so you guys hear it one time, the adrenal glands make testosterone as well, men and women. When they make too much, it's mostly noticeable in women, because obviously the changes are much more significant. However, only a small fraction of those are made, I mean, it doesn't make testosterone, sorry, I jumped the gun. It's androgens, which, go hand in hand a little bit with testosterone, kind of in a similar way, but obviously it's not the same. But it's just something very important to know, because not all come from, the adrenal glands. Most of them come from the testes and everything, or the gonads. But at least it's kind of something to know. I don't think it'll come up, but you heard it one time, so hopefully if it does.
If there's a question, where like, what makes a girl look more mannish, it's the androgen.
Yeah, so it's like.
Androgens?
Yeah.
Alright, so, from here, right, control of glucocorticoids, right? We just talked about it. Hypothalamus releases the CRF, the corticotropin releasing, remember, hypothalamus releasing, and then it causes ACTH to go from the pituitary to the adrenal cortex, which finally makes glucocorticoids. And then as mentioned, like always, negative feedback shuts off secretion of glucocorticoids. Right. So,
You good?
yeah, glucocorticoid hormones, right? What are they used for? Mainly short-term use. This one's a little weird with the acute flare-ups. I'm not too sure about that, because why would you want to, if it's an acute flare-up, maybe you want to give short-term use. But she just put this as its own category, so I don't know. It's just I'm doing my best here. I don't know. But long story short, we do know that for allergic reactions, we're trying to inhibit the immune system.
Mm-hmm.
Acute respiratory disorders, again, usually those are related to the immune system with high histamine release and all that stuff.
Yeah.
You want to keep that at a low, so short-term use, again, we don't want to use it long. But for sure, for things like organ transplant and cerebral edema, those are going to be for long-term use. So with these, again, what's the biggest thing with these types of short-term, long-term treatments? Do you give them every day? Do you alternate days? Do you...
You start
Go ahead. You want
No, I don't
The
know.
long-
Because keep in mind, there's a duality of glucocorticoid treatment. You either are doing replacement therapy, or you're trying to do something that's more related to this. For replacement therapy, how frequent do you give these meds? Every day. Because they're only replacement therapy. You're just bringing the body back to normal. But for these, are you giving a therapeutic dose, or are you giving a much more dangerous dose? Are you going to give that kind of dosage every day? You're going to give it every 2 to 3 days. Because you don't want to overload the body, and then now the person crooks. So yeah, pretty straightforward. No questions?
No, you explained that really well.
Right.
Anybody else? No?
Okay, so Addison's disease, right? My biggest thing that helped me is that Addison needs to add steroids. Mhm. Because they have primary adrenal cortical insufficiency. Do we know what that is? Primary adrenal cortical.
That's more confusing.
Okay, so to kind of give you a good idea, right? And if you want positive, just let me know.
For sure.
All right, so going back with Addison's disease, right? So now that we established what primary adrenal cortical insufficiency is, I already put a little reminder, the issue is with the adrenal glands, so the pituitary panics and creates more ACTH. We already established when there's issues with the thyroid in hypothyroidism, there's going to be high levels of TSH and low levels of T4, T3. Same rule of thumb with this. The body in primary adrenal cortical insufficiency, the hypothalamus and the pituitary gland are panicking. Why are we making these hormones? We're not making them. Maybe they're not hearing it. I'm repeating myself because it's a constant trend. Hey, they're not hearing it. We need to make more of the message, get it there, and maybe, just maybe, the hormone will be made. When unfortunately, the gland itself isn't working. So, our symptoms for having low levels, it's the same way that we figured out with kind of like thyroidism, but with low hypothyroidism. It's nausea, vomiting, which is kind of everything. Lethargy, the constant, the chronic fatigue that worsens over time, muscle weakness, because again, we're low, we're not using our muscles, we don't want to move. When you're very tired, are you irritable? You're very irritable. You have low levels of cortisol, which, as we mentioned, high levels of ACTH because the body's panicking, thinking that it didn't hear the message when it's not even working in the beginning. Anorexia can follow up, which is a little different compared to thyroidism, where you become higher in weight. So this one you just kind of have to just remember a little bit more with Addison's disease, like you need to add weight too because they're losing, they're having weight loss and all that. I mean, biggest thing too is like when they have like Cushing's syndrome, they gain weight because of the water retention. I guess just think the opposite of that. That's kind of the best way I can think on the spot to just remember, hey, they actually lose weight. And you could say like Addison needs to add more weight to her because she's losing it.
For sure.
Yeah, so again, as mentioned, our body's low, hypotension, hypoglycemia because our body isn't working as much. And then sweating because again, like you're gonna have just low, it goes hand in hand with whole vomiting, nausea and lethargy and stuff. So we move on to the next one. So corticosteroids, all of them for the most part can be taken by mouth, right? All of them. We have our cortisone, PL. We have dexamethasone. Yeah, dexamethasone. That one, the best way I can remember for routes, Digadrone, that one I'm like trying to think of, right? I've been trying to think of a way to remember the name of this one. But I don't know if you guys ever seen the show Dexter, right?
I've heard of him, I've never seen it.
Okay, so Dexter, he's a serial killer, but he kills other serial killers. Anyways, long story short, when he traps them, he always injects them. He injects them to knock them out. It happens a lot. So in this one, all drugs are PO, but in this case, Dexter, he ideally wants to inject into the muscle or into the IV to knock the patient, well, I shouldn't say patient, to knock the serial killer out in order to so an IV and IM, because we want to knock him out so he can kill him for doing whatever the hell they did. So, okay, so as for hydrocortisone, that one is kind of a jack of all trades. It's PO, it's IM, it's IV, and it's also subcutaneous. So that's kind of nice.
Cool.
It's one of everything. The only thing is that it is. Oh yeah, no. I was thinking too, it's not hypodermic, but it's you only give tuberculin injections for those, so it's not really that. Prednisone, PO only. Fludrocortisone for Addison's disease, PO only.
So all the ohms, all the sones, right?
So yeah, so for the most part, a lot of them are sones. They all end with sones, Sometimes cortisone, but when it's just a name, it's zone. Cortisone. Methazone. Cortisone. It's a recurring thing, so it's pretty nice. So big things always, pay attention to the suffix. As for the brands, I mean, unfortunately, that one doesn't really go hand in hand, but I don't know, maybe Dexter had a killer deacon that was doing bad things to kids or something, I don't know. Fludrocortisone, I mean, Florinef, sounds like food, I don't know, yeah.
Florinef, Cortef's on the light.
Yeah.
And then there's Cortef again,
Yeah.
Solu Cortef.
Yeah, well, this one was from a med card, and those were, you know, like Cortef, Solu Cortef, there's Aquacort, Hydrocort, again, because of the name, Hydro Aqua. So,
Yeah,
okay.
yeah.
And then prednisone, what's that one? That one passed my mind for brands. I forgot about that one, but anyways, we can just kind of move on a little bit. So, corticosteroid treatment, type drug, as mentioned, hydrocortisone. It's like, the rule of thumb is going to be basically followed by everything. Those are the- So, primary use, drug of choice for treating adrenocortical insufficiency. Again, we're doing therapeutic dosages. We're not really trying to prevent any crazy disease or anything. But common effects, as mentioned, are signs of hyper secretion of corticosteroids, aka Cushing's syndrome, right? So the hyperglycemia, because lipids, proteins, and carbs are turned into glucose. False leukocytosis, that's just something you just unfortunately need to know. I can't really come up with like a good connection to that. But we have hypernatremia because, again, our mineral corticoids, they're encouraging the reabsorption via aldosterone to retain fluid. So you're going to have higher levels of sodium because the sodium retains water, which is what aldosterone does. It encourages that. So you're going to have high levels of sodium. Hypercalcemia. So it's weird because Cushing's syndrome, this is basically what it is, can both cause hyper and hypocalcemia. So it's like, maybe it could initially cause hypocalcemia, you know, because all the calcium is used up in the body. And now it needs to pull it from the bones, as mentioned, pulling calcium from the bones to the blood, to the serum. But maybe it could also run out because it just used it all up, which, you know, again, this is why it causes osteoporosis. But it's just something because it's funny. In this slide, this is mentioned hypercalcemia, but in a couple slides, you're going to see that it also says hypocalcemia. Yeah, so that's one thing. And then hypokalemia, that one is given because instead of sodium being excreted, potassium is excreted out now. So again, now you're losing because in the end, you're going to have to lose something when you're urinating something out. It's either going to be sodium or potassium. And your body wants to keep the sodium. So it's either sodium or potassium. Well, it wants to keep this one, it's going to give this one away. Adverse effects, as mentioned, we know this. Sodium and fluid retention, the hypernatremia, the hypertension, and the weight gain that you get. CNS effects, insomnia, just like hyperthyroidism, the anxiety, the headache, the vertigo, the confusion, depression. So it's all, I mean, depression is late stage, but, you know, like you get so tired of having to deal with all this. But again, like headaches, you have high blood pressure. What happens with patients who have very high blood pressure? They have a headache. They hear the, you know, the ringing in the ears. There's like very dangerous things about like the warnings of stroke, like big things like that. You know, hand in hand, sodium and fluid retention, that means hypertension, the tachycardia, peptic ulcer disease. Remember, if you take these with like insects, it just makes it more prevalent. And then our Cushing's syndrome, this is legit what Cushing's syndrome typically has. Yeah. Pretty straightforward.
Yeah.
Okay, so Cushing's syndrome, typically two causes, right? Hypersecretion of the adrenal glands for the entire body, or overdoing treatment, like long-term therapy for autoimmune diseases or whatever. So big thing, right? I like what you said with that one thing about the tumor makes it so the gland atrophies, because Cushing's syndrome happens a lot with adrenal atrophy. Because if you have a tumor, and that tumor is making it, the tumor, we can kind of like separate the tumor. This is normal tissue, this is the tissue of the tumor. This one isn't making any hormones, this one is. So if we're not using it, are we gonna lose it? Yes. And this one's being used because, it's cancer, so it's kind of overdue with anyways. As mentioned, the osteoporosis, because of the, why is it? Again, we're pulling calcium from, because the body needs calcium to,
Work, muscle control.
muscle contract. We need to constantly pull that. And then, hypertension because of fluid retention. Increased risk of infections, why is that?
You're suppressing the immune system, no?
You're suppressing your immune system, delayed wound healing, same thing.
Yeah.
You're suppressing your ability to heal and fight off infection. Acne, steroids.
Oh, yeah.
Peptic ulcers, we already talked about that. Your body's working so hard, you're building up a lot of acids. You're gonna maybe freaking put a hole in your stomach. General obesity. Redistribution of fat. Moon face, buffalo hump. You look like a cushion with Cushing syndrome. Because you start getting all puffy.
Yeah, puppy.
Yeah. Mood and personality changes may occur. Steroids alter your mood. Roid rage and all that crap. So, there you go. Let's move on to the next one.
Technical difficulties.
Yeah, we're good. Okay, so pharmacotherapy of Cushing syndrome, right? So, treat cause of excess corticosteroid. Obviously, the first thing, if you're giving long-term treatment, you want to gradually stop corticosteroid treatment. What happens if you abruptly stop corticosteroid treatment? What happens? Oh.
Your gland may not produce the right amount, right?
And that is called a
Withdrawal.
John, come on. I know you know.
Is it shock or something?
Yeah.
It's in the realm of it. It's called an adrenal crisis.
I read that earlier too.
Yeah. It's an adrenal crisis. That can land you into a coma. And then that can kill you.
Damn.
Yeah. Because your body, again, it's like when you take a lot of steroids and your nuts shrink. You've been taking so much steroids by IV that your gonads are like, well, we don't have to make any more. So because of that, we're like, well, I quit. And now this is the same thing. So if you abruptly stop, that's why you also need to, like, if someone had too much steroid treatment for testosterone and all that crap, they need to gradually lower the dosages. Because if not, if you stop cold turkey, you're going to die. So, ketoconazole. These are all pasireotide, Signifor, and middothane, lysindrogen, and then midarapone. I usually think martyr, like a martyr. Maybe make a martyr out of them or something. It's a steroidogenesis inhibitor, same effect as the other ones. Ketoconazole. I did add this list for my notes to help people understand a little better. I hope that helps. So the ketoconazole is, if I recall right, it's in the family of antibiotics, I think, that mainly, well, more importantly than anything, is that one helps inhibit the production of glucocorticoid production. The only issue is that a tolerance can be built up to it. And then at that point you can't really use it and you're back to square one having Cushing syndrome. Pasireotide is a synthetically similar drug that appears similar to somatostatin.
Growth hormone.
So, not necessarily. So that's growth inhibiting hormone. Somatotropin is growth hormone. Somatostatin is a inhibiting hormone. Obviously, to kind of revert back a little bit, right? Somatotropin, remember, it has the suffix of tropin. Tropin usually means encourage, creation, production. Somatotropin, growth hormone. You're going to be growing, whatever. Statin, usually your statins mean static, stopping, not dynamic. You're freezing, you're inhibiting. So, pasireotide looks very similar and acts very similar to somatostatin, a growth hormone inhibiting hormone. This inhibits ACTH production, because again, it goes hand in hand all the way back to the master gland in the pituitary. Right? And then finally, midopain. That one is mainly given for cancer. It mainly attacks tumors that create a lot of corticosteroids that lead to Cushing's syndrome. It is not necessarily approved for Cushing's syndrome. It is mainly approved to target cancer cells in the adrenals. So big thing to notice. So midoripone, again, that one you're just gonna have to. I just only had to recognize it visually. Margaritone, Mediripone, or whatever. I mean, luckily the brand name looks fairly similar.
Yeah.
So that's one thing. But just big thing to note, it's a steroidogenesis inhibitor, just the same way as all these. I'm not really sure too much on the specifics because there's so much to cover. I'm hoping that's one up. Watch there be a question asking some super in-depth question about this thing, I swear. Okay, so we can move on. Right? So this is pretty much the effects of long-term corticosteroid therapy. So, eye changes. It's very prevalent that you have, I believe, it was cardiac cataracts and open-angle glaucoma. Because again, usually, what are the most sensitive tissues in the body? The eyes.
Oh.
Usually if something fails, or like something relating to muscle, the eyes are the first thing to go. That's why like blindness is usually very common and like lots of diseases, like especially like diabetes, same thing. Too much of it, it screws your eyes. Immune response, immune suppression, as mentioned, everything else. You have lower ability to fight off any foreign foes. You can't heal as good. Metabolic changes, again, your body's just, you're going to have higher levels of lipids because now those are just ready. Those are ready because the body's taking all the lipids, all the proteins, and turning them into sugar in order for you to produce, whatever. Produce, your glucose and all that stuff. Well, I said it wrong. It's your proteins, your lipids, and your carbs to produce glucose. Yeah, sorry about that. So, same thing, we have hypernatremia, very big thing, because again, the constant reabsorption of salt that leads to that hypertension, the fluid retention, the high weight. And right there, we just covered it. And then what happens when you have a lot of weight covered, like you get edema in the tissues. Myopathy. Again, you're taking protein and turning it into sugar. That at some point is going to be coming from your muscles. It's going to lead to myopathy. The same way how osteoporosis, you're pulling calcium from the bones because you need it. You're prioritizing. Your body's like, hey, this is coming first. So screw your muscles and screw your bones. We need everything here. Peptic ulcers. Just harder working body, you're creating more acids, which is going to freaking cause all that. The behavioral changes, the nervousness, the moodiness. There you go.
Yeah. I want to say ulcers are common in like steroid use too.
Yeah.
Like,
Because again, they go hand in hand with everything, like in terms of cortisol. Not exactly one by one, or one-on-one, but it's very similar. So, corticosteroid therapy for the role of the nerves, right? Always assess vitals and temperature and blood pressure. We always do that. I say we like we are, we're not even nurses. Monitor potassium, as mentioned, T3, T4, and glucose levels. So I forgot to mention it earlier. we kind of passed it a little bit, but high levels of thyroid hormones, like T3, T4, if they are very high and in conjunction with, for instance, Addison's disease or primary corticosteroid insufficiency, that can cause you to have an adrenal crisis. Because it's almost like, the way I like to rationalize it is, so it sounds like conceptually, who knows actually in full way, but it sounds like the thyroid and the adrenal glands have somewhat similar functions. Not the same, but pretty alike, kind of alike. You know, they both have that high heart rate, the high blood pressure, and all that. It's just done a little differently, right? But could it be that because your adrenal glands in primary adrenocortical insufficiency are shot, right? It now makes your thyroid take over, because our body is amazing like that. One thing fails, something else will take the slack. And because of that, again, now the thyroid is making lots of hormone because it needs to work double. And then, what happens if you don't use it? You lose it. So now you lose your adrenal gland function because now it's not making anything, and that can land you in an acute adrenal insufficiency, aka adrenal crisis. And that was earlier in the text. That's why it's important to monitor your T3, T4 in this as well, because if you have high levels, you can kind of predict an adrenal crisis. You can prevent the patient from going comatose.
Adrenal crisis, coma, death.
Okay. That's like the biggest silent symptom. There's like the diaphoresis, the nausea, vomiting, but those are kind of like all diseases or conditions, or a lot of them. But the biggest one is coma, because you need, again, it's like that steady state we were talking about, homeostasis. Do you want to be over and you want to be low, or do you want to have in the middle?
You want to be
in the middle. You want to have that constant state, right? So, glucose level, same thing. Your body is creating way too much sugar from both proteins and lipids and carbs that we already had. You need to watch those blood sugar levels because they're going to skyrocket. And obviously, if somebody's blood sugar levels are extremely high, as we learned with diabetes, that could end up kind of reaching to the point of insulin resistance and all that stuff. Same thing too with patients with diabetes. If they are taking high dosages, adrenocorticosteroids or whatever, they probably want to readjust their insulin, because maybe what they're taking right now to treat for the glucose, high levels and all that stuff, might not be good when they're taking high dosages that are creating way too much sugar. So pretty straightforward, right?
Yeah, I mean, right, you gotta monitor potassium because they're holding on to the sodium and excreting potassium.
Yeah.
T3, T4, right, because of the adrenal crisis. Glucose levels, right, because they are also, if you're at Cushing's, right, you're also producing more glucocorticoids, steroids, right? So your sugar's gonna go up.
Yeah. And again, with diabetics, you gotta. Can we pause it real quick?
Whoa.
My bad.
You're good, you're good.